Well, hello and welcome to our very first Zoom session for Hearing Disorders 125 in the year of our Lord 2018. Here we go. Basically, let's just kind of lay a bit of groundwork here as we start. First, a couple of things we should always remember regarding our weekly Zoom sessions. We'll have them every week. I'll try to do them on Tuesdays here at 11:30 Central Time. It's 9:30 Pacific Time where I am on the west coast of Canada. But at any rate, the Zoom sessions always should go for about an hour, maybe an hour and 15 max, but usually about an hour sharp. And it's always a good idea never to watch the darn Zoom sessions on your phone. You gotta have a regular sized desktop or laptop computer with a decent sized screen in order to see the ding dong things. It's always good to check Canvas every week and make sure that you've watched the particular Zoom session of concern, because most of your material is really condensed in these Zoom sessions. You've got readings and everything like that, which is just great. And those are books that I would be keeping with you when you go into your practice in your future careers. But for now, really concentrate on what's covered in these Zoom sessions, because they contain your notes and your PowerPoints that tie together. And each week I talk to you on these Zoom sessions straight from the notes and the PowerPoints that are uploaded on Canvas. So for this week, it's Unit 1. Next week will also be Unit 1. I'll kind of lay out the course here. I'll see if I can share screen and then show you basically what it is that we're going to be covering in this course and kind of the schedule in which we'll cover it. So if you look here, you're going to see, I'll make this larger here if I can get rid of that bar that always appears. That drives me crazy. Okay, if I make this larger here, and you will see, along with me, oh yeah, you got some bunch of quizzes here. Look at this. See this? Look at that. You got your quizzes, 1, 2, 3, 4, 5, and 6. Okay? Basically, it's only an 8-week course. And the last week of these 8 weeks is your final exam. So really, we only have 7 weeks. We plan to spend 2 weeks. Now, last year we had Unit 1, air conduction and bone conduction and tympanometry. You can see the notes where my cursor is and the PowerPoint where my cursor is. Well, this year, because of the shortness, the brevity of the course, I took that out. And we're starting right here where I'm pointing, Unit 2, okay, and Unit 2. These three, you've got 2 PowerPoints in red. Unit 2, Hawk, TM Gallery, that's a physician by the last name of Hawk, and tympanic membrane gallery. We'll look at all kinds of eardrums, okay? And then you have a PowerPoint for this unit. Now, bear with me, okay? I shouldn't have even had these here. I'll take these Units 1 and Unit 1, air conduction, bone conduction. Ignore those. Unit 2 is really Unit 1. These 3 that I'm circling, the middle one here, Unit 2, notes, outer and middle ear disorders. Unit 2, PowerPoint, outer and middle ear disorders. And Unit 2, Hawk, TM Gallery. Those are the 3, those are the 3 PowerPoints that I have uploaded onto what you know as Unit 1. So inside Unit 1 in Canvas, you will see these 3 documents. Hello, Renee. Good to see you. I can see you up in the corner of the screen. Good to
have you doing?
Okay. Let's see. I'll stop sharing. There we go. All right. How's your summer? You had a good one so far? Good to see you.
So far, so good. You too. How are you doing?
Yeah. We finally got some rain, which is always good, but I had a little bit of a break between spring semester and this one, and but now we started. I was just saying how short this course is. It's only 8 weeks.
Yeah, I know.
So in the first 2 weeks, we're going to cover Unit 1, which is outer and middle ear disorders. We'll spend this week and next week doing that.
Okay.
And then in Unit 2 is inner ear disorders. And we'll cover that in weeks 3 and 4. Weeks 3 and 4, the cochlea, inner ear disorders. And then Unit 3 is going to be retrocochlear pathology, eighth nerve pathology,
Okay.
flags. And we'll spend 2 weeks on that. So 2 weeks on outer middle, 2 weeks on inner, 2 weeks on retrocochlear. That leaves us with week 7, which is pseudohypoacusis. People who like to lie about their hearing loss.
Yeah.
We spend 1 week on that, because that's a disorder too, but not actually a physical disorder. It's kind of like a mental disorder. But at any rate, and then we have the week 8 is the final exam. So there are, I think I've uploaded for Lynn Royer 6 quizzes, and they're kind of meant to be given by the week. So I think you'll have 6 particular quizzes given, and I'll let Lynn Royer be the boss of, what do you call it, releasing those at their due time. But I encourage all listeners to follow or make sure you do those weekly quizzes that follow closely on these units. So Renee, where are you now? Are you still in Texas? Are you in San Antonio still or not?
Yeah, I'm still in San Antonio, Texas.
Okay, all right. And you're moving through this program and
just the program's great, and just trying to find a clinical area, a site, and trying to find a job in the field. And that's the only thing that. And
is it good? Does it look like you'll find something in your area, or you're going to have to move out of state?
I've considered moving out of state. So I don't know. I'm looking. See, I'm hoping to stay here, but if not, I have to move. I will move. To certain areas, not anywhere.
Yeah, I get you. I get it. It's funny. Sometimes you have to move out in order to move back. And you move out and you get experience and stuff like that, and then all of a sudden you'll hear of something in San Antonio, and all of a sudden, boom, you're back in Texas again.
Exactly.
That's what happened to me too. It's I had to leave in order to come back. I lived out in the Toronto, Ontario area for years, and I got family there, but I'd much rather be here on the West Coast, or as we call it, the wet coast.
The wet coast.
Yeah, I get it too, that there's certain places you don't want to be either.
Exactly.
But we won't mention them here on the Zoom session. All right, good stuff. I'll start on the outer ear, and I'll share screen and show some notes and PowerPoints that we've got pulled up there. And let's see here. The notes are really quite simple. If I look at the notes here, it's basically, if you'll watch with me, it's page 1, and we're looking at outer ear disorders. And look at this, outer ear and audiometry and outer ear disorders. And by the time you've gotten to this area right here where my cursor is at the bottom of the page, you're already at otitis media. You're already at the middle ear. So page 1 of this 4-page note session is on the outer ear. So you can see that most ear pathology does not really deal with the outer ear. The outer ear is basically wax. You're really not looking at a lot. But let's look at a couple of PowerPoint slides as well concerning the outer ear. And I'll go into, what do we got here? Let's look at outer ear and go to the very top. Okay. So, some things about the outer ear canal. Remember, the inner half, the skin covers bone. The outer half, the skin covers cartilage. And we've always said that's much like your nose. If you grab your nose, you can bend the end of it because the skin covers cartilage. The top part of your nose, the skin covers bone. Now, wax, remember from anatomy class, wax forms from the cartilaginous portion of the ear canal, not from the bony portion. The skin in the bony portion is very smooth. There's no glands that produce wax there. There's no hair growing there. It's in the outer half, which is why when you use Q-tips, you only jam wax further in where it never started in the first place. The outer ear canal resonance, remember the outer ear canal resonance and speech, okay? This outer ear canal being a quarter wave resonator, 2.5 centimeters or 1 inch in length. It's going to naturally resonate with sound waves 4 times their length. And that resonance, if you boil down the math, which we did in acoustics class, is going to give you an added decibel resonance between 1,500 and 4,000 hertz, which is precisely the sweet spot of the high frequency consonants of speech. And so the outer ear is naturally made for hearing speech. And we can see that here when you're looking at the letters on the audiogram. I'll make this larger here so one can see it even more better, as they say. And you're looking at the letters of speech are the high frequency consonants. See that those are naturally lifted by this outer ear canal resonance. And the outer ear canal resonance, of course, is produced by the length of the outer ear canal and the concha bowl. Therefore, the outer ear resonance. The middle ear, we said in anatomy class, that increases the sound pressure level of airborne sound so that it can activate a fluid-filled cochlea. Remember, the cochlea on the right is filled with paralymph and endolymph. Sound waves coming through air are airborne sound waves. And those sound waves would bounce off the fluid, because just like if you had your head under a pool and I was standing outside the pool talking to you, you would not hear me because my voice would bounce off the water. So the size of this drum relative to the size of the footplate of the stapes, force hitting a big area, not much pressure. But with that force is converged onto a point, you've increased the pressure. And we said in anatomy class, this is the way the middle ear, there are 3 basic ways that the middle ear increases sound pressure. The biggest one is number 1, size of the drum relative to footplate of the stapes. Number 2, the leverage action. The manubrium of the malleus is a little bit longer than the long process of the incus. And the third is the buckling action of the eardrum. These 3 things together increase the pressure of airborne sound so that it can activate a fluid-filled cochlea. And there's the summary right there, shown in terms of math or on the graph. You know, the eardrum to stapes size, 17:1. Ossicles leverage action, 1.3:1. Eardrum buckling action increases the pressure by 2:1. Combine them together, you have a 44:1 pressure increase. And if you look on the horizontal axis, if you've increased the pressure by 10-fold, you've gone up 20 dB. If you've increased the pressure 100 times, you've gone up 40 dB. The 44:1 pressure increase offered by the middle ear is somewhere between 10 and 100, and if you did the math looking in orange, you'd end up with somewhere between 30 to 35 decibels of increase due to the middle ear, which is cool. And we said in anatomy class, this is tying courses together, but it deals with pathology, okay? The Rene tuning fork test. Go away, bar. I can't stand you. Go away. Anyway, bye-bye. The Rene tuning fork test. Dr. Heinrich Rene, okay? A tuning fork held by the ear. I wonder if I've even got a tuning fork here. Sometimes I have these puppies hanging around, and sometimes I don't. Yeah, oh, no, I don't. This is just... Nah. Okay, anyway, a tuning fork held by my ear, you're going to hear it loud. But if I ding the tuning fork and I hold it by my mastoid... Good. Hey, Sam, how you doing? Good to have you join us. All right. So if I take a tuning fork, strike something, and put the end of it on my mastoid bone, I'm going to hear a sound. But if I pull it away and hold it near my outer ear, it's going to be a whole lot louder. And that was what we called the Rene tuning fork test. And it's the best demonstration by far of those 33 decibels that's added by the middle ear. What you're seeing on this graph here, you're experiencing when you're doing the Rene tuning fork test. So next time you're ever at an office that has a set of tuning forks, try this. bang your knee with the tuning fork and hold it against your mastoid bone, and then hold the tines near your outer ear, and you'll notice that the tuning fork heard by air conduction is way louder than the tuning fork heard by bone conduction. It's the best demonstration of the middle ear's purpose. And who is going to experience this? The person who does not, repeat, not have middle ear pathology. Okay? And who doesn't have middle ear pathology? Normal hearing and sensory neural hearing loss. But if you have a conductive hearing loss, an air bone gap, the René tuning fork will not sound louder by the outer ear. It'll sound the same if you hold it by the mastoid and if you hold it by the ear. You will not notice that 30 to 35 decibel increase offered by the middle ear. And why? Because your middle ear would be fried. It's not working. Now, here is something called atresia. This is a pathology of a disorder of the outer ear, obviously, and this person was born this way. And atresia, you can see he has no ear canal. This person cannot wear normal hearing aids. This person likely has normal cochleas, normal inner ears, but no outer ear canal. May or may not have middle ears. We don't know. But this way here, this is associated with the syndrome called Treacher-Collins. Treacher-Collins kids often have the eyes are very close together. Treacher, T-R-E-A-C-H-E-R dash Collins, C-O-L-L-I-N-S, Treacher-Collins. Treacher-Collins is a syndrome, genetic inherited syndrome, and the children have they look a little different. The eyes look a little bit different, and the ears often have atresia. These people are now given bone conduction hearing aids. It's called a BAHA, B-A-H-A, bone anchored hearing aid. Really quite cool. What they do is they drill into the skin, or they make a flap of skin, and they drill into the skull, maybe about 1 centimeter, just a little bit, and they put a screw in there. And the screw has a magnet on top. It looks like a tack. And so this is drilled into the bone, and then they put the skin back on again and let it heal. And then after about 6 or 7 weeks, a hearing aid with a magnet sticks onto that, and you're delivering the sound through bone conduction straight to the person's inner ear. Bone anchored hearing aids. Who are they for? People who cannot wear conventional hearing aids because maybe they have weird ear canals that just can't accommodate it, or maybe they have what's called atresia. Let's look at more pictures here. Go to this guy here. See, here's an old-fashioned bone-anchored hearing aid. Now, this person has obviously atresia. This person has Treacher-Collins syndrome, outer ear pathology, no ear canal whatsoever, and he's wearing, look at this, like a headband, like you're doing bone conduction audiometry. The hearing aid is here, and the bone conduction oscillator is placed on his mastoid bone. Now, we don't do that anymore. This is rare. We mostly use the bone anchored. Here's a bone anchored hearing aid. This child has Treacher-Collins as well. And you can see the bone anchored hearing aid behind her hair. And this is, the implant is directly into the mastoid bone. The headband is gone, and this is sticking onto the head by way of a magnet. Hey, osteoma. All right, have a look at this. Swimmer's ear. Benign bony tumors of the outer ear canal. These are not cancerous. As long as they're not blocking anything, they're fine. It's called an osteoma, osteobone-oma tumor. And they are caused by people swimming in cold water. And the body naturally tries to protect the eardrum from the cold water. You can even see the cone of light here. Now, if you were being quizzed on this, what ear do you think this would be? The cone of light is normally at 5 o'clock when seen in the right ear, and it's normally at 7 o'clock when seen in the left ear. Just thought I'd tell you. Here's good old soft wax. Now check this out, wax of the outer ear. Now this is new wax. It's nice and soft and yellowy, gummy, gooey, and you can see there's still a hole here. So this person will have no hearing loss due to this wax. But of course, if you jam a Q-tip in there, you're only going to jam it further, and you might plug up the ear canal. But even if you plug up the ear canal, you're only going to have a mild hearing loss due to wax. Wax does not create that much hearing loss, maybe 25 dB max. You're really not going to get a lot of hearing loss due to wax. Now here's older wax. You can see how it's darkened. You know, it's got more debris and dirt in it. But still, you can see there's a slit. And as long as you can see a slit, there's no hearing loss due to it. Now, the hearing instrument specialist can sometimes go in with a curette, and you can hook, if you're looking in carefully, and pull that right out. You should take cerumen management courses, though. They do offer IHS. You can go on their website and find out where to take cerumen management, and it's often offered by various clinics and things like that, and you can learn how to remove wax. Also, if you happen to work in an ear, nose, and throat office, the doctor there can train you too. But knowing how to remove earwax is kind of handy. It's a smart thing to be able to do without having to refer the client all the time. Now, this is kind of interesting. Collapsed ear canals during air conduction testing. Now look at this carefully. Here's an audiogram. And this person has a rare high-frequency air bone gap. Look carefully at this. The bone conduction is here at 40, and the air conduction goes below. So you've got an air bone gap in the high frequencies. Now this is not common. Do you know what causes it? Circumoral headphones. When you're using those over-the-head circumoral headphones, not the inserts, okay? You're squeezing someone's ear canals, especially the elderly. They are losing cartilage in the ear canal. And so then the ear canal gets collapsed during the hearing test. And when testing with circumoral headphones, if you've got a high frequency air bone gap, try to replace the headphones with insert headphones. And that forces the ear canal to be open. Most air bone gaps occur in the low frequencies first. Like if you've got an ear infection, which we'll be talking about later, otitis media. Okay, if you've got an early otitis media, you'll have a low frequency air bone gap, and then that will spread into a high frequency air bone gap. But mostly having just a high frequency air bone gap is rare. And so one of the main causes for it is collapsed ear canals. I'll say something else too, though. Once in a while, when testing bone conduction, you are going to see these weird, kind of like 10 decibel air bone gaps in the high frequencies. A lot of people ask about it. There's been inquiries made to audiometer producers, and if you go into Academy of Audiology online, there's questions and queries about it, and it has to do with calibration and placement of the oscillator. You're going to notice these odd things that happen once in a while. I'll just say this, FNO, freak not out, okay? You sometimes see like a 10 dB air bone gap at 2000 and or 4000 hertz, which is not even due to collapsed ear canals. And this just, no matter, don't freak about it. It's usually some type of a calibration issue in the audiometry. I say that because you'll probably encounter it, and then I want you to think about this conversation we've had. Anyway, we got a fourth person, Nicole. Great. Howdy doody. All right, we be all here. We're the only ones that are going to pass this course. Screw the rest of them. They're failing. Now, okay, here we go. All righty. Let's see what other pack of lies I can show you here on this PowerPoint. Okay, look at this. This guy's got normal air conduction. Air conduction for the left ear is around 25, and this is due to external otitis. Now, if you break down that word, external, well, outer, otitis, oto, ear, itis, inflammation. Obviously, an inflammation of the ear canal. The ear canal is probably really inflamed and blocked off, so instead of wax causing the hearing loss here, it's the squeezed ear canal that's swollen shut. So you don't see that too often. Okay, now you've all seen this one here, but it's time for me to move on. What I want to do is stop here and go to the notes so that let's see what we've covered regarding the outer ear. Outer ear disorders. Microtia. Circle the word, okay? It means little ear. Okay, just like you saw with Treacher Collins, those pictures I showed you there. And then you're going to see anotia, that means no outer ear. You'll see the word atresia, and there it is, associated with Treacher Collins syndrome. The cheeks and facial bones are not well formed. All right, and recall as well, I think from anatomy class, I'm not sure. You know that little thing that you have under your nose there? Remember I told you last year that's where the angels pushed you out of heaven? Okay, that's how you came on the earth. Okay, but your face is formed from 3 pieces. The middle piece and the sides. And they form together right at your canine teeth. You see your 4 front teeth come from one bone plate, which is associated on the skin with this thing. This thing under your nose is called a philtrum. P-H-I-L-T-R-U-M. You know what? One of these days you're going to get on a television show that's going to win you $1 million if you know the name of that little piece of skin under your nose that everybody has. And you'll say, oh, that's a philtrum. Ding, ding, you just won $1 million. Nobody knows that, okay? Jeopardy or some crazy thing. Anyhow, your face comes together with those 3 plates, your cheek, this cheek, and that middle piece. And if they don't come together correctly, you'll have a cleft. And some people have a cleft palate here. Some people will have the cleft palate there, and some people will have the bilateral cleft. Okay, Treacher Collins isn't cleft palate, okay, but it is a malformation of the cheek and facial bones. The eyes are kind of close together, and the children are often born with anotia or atresia or microtia. So these are things to know. Stenosis. Stenosis is any narrowing of an ear canal. Okay, stenosis doesn't cause hearing loss, but stenosis can be caused by wax, that narrows the ear canal. Stenosis can be caused by a swollen ear canal, a narrowing of the canal due to swelling. Or stenosis can be caused by a bug in the ear, maybe a cockroach crawled in your ear, yikes. Well, that's going to create a narrowing of your ear canal. It's going to hurt like hell too, but anyway, or some kid that stuck some beans in his ear, excuse me. Anything that jammed in the ear canal can cause stenosis, including cerumen, which is earwax. Okay, so atresia is a total closed canal. Stenosis is a partially closed canal. Just words that is handy for you to know as a clinician. You're going to run into these terms. Audiologists and HISs use them. Physicians use them. So it behooves of us in a hearing disorders class to make sure we've got these puppies down. All right, external otitis, we covered that. Inflammation of the external auditory meatus can be caused by swimmer's ear. Maybe you got a fungal infection from water trapped in the ear canal. Myringitis, inflammation of the tympanic membrane. And then you saw this, osteoma, bony tumors in the ear canal, sometimes seen by people who swim in cold water. Cerumen, earwax, produced by glands. Remember where that grows, in the cartilaginous portion of the ear canal. The hearing remains normal as long as an otoscopic exam reveals a visible eardrum, as long as there's a hole, as long as there's any kind of a hole or slit that the ear canal is not totally blocked off. You shouldn't be seeing any hearing loss due to wax. And if it is closed off, you'll see only a very mild hearing loss. People think earwax causes a big hearing loss. And then they'll go all to these quacky places that offer ear candling and all that stuff. And you know, the wax from ear candling is from the ding dong candle. Anyway, eardrum perforations from trauma or middle ear infections. Perforations in the inferior portion of the tympanic membrane heal faster than others because the skin migration is faster there. Sometimes a hole in the eardrum, if it's small, they'd actually lay a piece of cigarette paper over top of the hole on the eardrum to provide a scrim for the skin to grow across. That can only be done if there's not too big of a hole in the drum. So as long as the hole in the drum, if it's a pinhole, it'll heal by itself. If the hole is about yay big, about a millimeter or two bigger, they'll put a cigarette paper across, I don't know, probably Vogue, I don't know what kind, zigzag, who knows. Roll one up. Anyway, they'll lay it across the eardrum and the skin will grow across. If the hole is too big for that, they'll take skin from behind the ear and they'll actually do a myringoplasty. They'll do plastic surgery and try to, create a new eardrum that way. But these are pathologies of the outer ear. And this is the smallest section of the course because pathologies of the outer ear are really quite simple. The middle fibrous layer of the eardrum, remember the eardrum has 3 layers, okay? The inner layer, the outer layer, and the middle layer is shaped like a spider web. It's the tough layer. Remember the eardrum's the only place that has all 3 layers of original embryologic tissue: ectoderm, mesoderm, endoderm. Anyway, myringotomy. Know the difference between myringotomy and myringoplasty. Myringotomy is a hole or a puncture of the eardrum, sometimes done by a physician to get rid of fluid behind the ear. That procedure is called a myringotomy. And they'll stick something in there and suction the fluid out, the infected fluid. This is something done by a physician. Myringoplasty is a surgical repair of a perforated eardrum. Every time you see plasty, think surgery, plastic surgery. Itis, always think infection or inflammation. Vein tissue sometimes works better than than skin tissue. Fascia, tough, fibrous tissue covering the muscle, is actually the best because it creates a stiff kind of a skin tissue that imitates the stiff eardrum. Monomeric eardrum, remember what that is. It's a very thin eardrum. It's missing the middle layer. Could be due to eardrum injury, could be due to repeated otitis media and repeated perforations of the eardrum, an artificially flaccid eardrum, very unstiff. It's missing that stiff middle layer, that spider web layer. The opposite would be tympanosclerosis, a thickened eardrum due to scarring, calcium plaques. And you can see this often when you look in someone's ear canal. You'll see some really weird looking eardrums, and we're going to take a peek at that. Audiometry here, outer ear disorders can be very painful due to pressure from the headphones. Remember that. If you've ever had outer ear pain, it's very, very strong. It can be very bad. Outer ear disorders can result in very mild conductive hearing loss. Put a star by that. Air-bone gap. Outer ear pathology and middle ear pathology do not, repeat, not create elevated bone conduction thresholds. Sounds presented through the mastoid bone are going to be heard perfectly normal. Okay, outer and middle ear pathologies will result in hearing loss for sounds delivered through a headphone. That's called air conduction. So outer ear pathology, middle ear pathology create a conductive hearing loss. And when you think of the word conductive, think of electricity conducting through a wire. Conducting just means passage. It's just a passage, okay? Your car is being conducted down the road. A conductor of a train drives the train, okay? You're moving. So conduction just means a mechanical blockage. A mechanical blockage due to wax. A mechanical blockage due to a ruptured eardrum. Mechanical blockage due to an ear infection. Conductive hearing loss. Air conduction scores will be elevated. Bone conduction thresholds will be totally normal. Watch out for collapsing ear canals, as I said. We've covered that, so let's look at some really weird eardrums together. So here we go. Check this out. Every once in a while you'll get some men come into your office, and a lot of older men have hairy ears. Now check this out. Yeah, you're going to have to look in this guy's ear, and it may be that if you needed to take an ear mold impression, you may need to trim the hairs first. This happens, okay? Not so much in women, but in men. Men get hairy ears. Here's a person with atresia, okay? And remember, the hair on ears grows from the tragus. Look at the tragus. Tragus in Greek means goat's beard. Can you see now why? Okay, tragus is the Greek word for goat's beard. Hair grows on the outer portion of the ear canal and from the tragus. Anyway, here's atresia. This person has microtia, a small ear, and a completely blocked ear canal. Surgical reconstruction may be successful in the presence of a relatively normal middle ear. So if they've done a CT scan or an MRI and they found out that, hey, there's actually an eardrum and there's actually 3 little ossicles there, then they may do surgery. Here is a normal tympanic membrane. Have a look carefully at the landmarks. Cone of light, 5 o'clock. It's a right ear. Grayish, translucent, that means light can go through it, but you can't see, you only see shadows. What do you see? The manubrium of the malleus, the umbo, the long process of the incus, and even the neck of the stapes. You can see a little bit of that, okay? So make sure that you've got this down, so the manubrium of the malleus, the umbo, the cone of light, the long process of the incus, and even the neck of the stapes. You're not going to get this classic view from everybody, but here's another eardrum, a right eardrum. Different kind of lighting. Look at all the capillaries here, the umbo, cone of light once again. You can't really see the neck of the stapes very much through here. I have a hard time seeing that. I can't quite see that as well. Here it is closer up. And we are looking at outer ears. So let's just kind of take a good look at these pictures here. Okay? You can see the manubrium of the malleus. I'm not sure what this is. Long process of the incus? Not sure. But it's a good, healthy eardrum. If you see a cone of light, that means it's a fairly decent eardrum. Now here's looking in an ear canal. And you're looking at a little bit of wax forming in the outer portion of the ear canal. This is normal. This is where the sebaceous glands produce wax on the cartilaginous half of the ear canal. And it's all normal. Nothing wrong with this. You can see where the hair is. You can see the wax beginning to form. Healthy, just like mucus in the nose, natural. Now when you look to the right, you're looking deeper in. When you're looking deeper in, you can see that the skin gets smooth. There's no more hair. The skin is smooth. There's no wax. So when you use a Q-tip, you're only jamming wax from the outer portion and you're pushing it in further. Now here's wrinkles in the external ear canal. The skin actually migrates out. And sometimes toward the outer part of the ear canal, you can actually see little bumps. And that's the skin, like a traffic jam of skin and the development of the wrinkles as is seen. Here's earwax again. Slight earwax beginning to form. Nothing unnatural about that. Ooh, there's a good chunk of wax for you. Will this person have hearing loss? No. Okay, because you can see beyond the wax. Sound can get past there. The person will not have any hearing loss whatsoever. New wax, it's soft, yellowish brown. Now here's variations of earwax. Look at this stuff, okay? Newer earwax, older earwax, darkest earwax. It just depends on how much dirt and debris is mixed with the cerumen. Here's an example of stenosis, acquired stenosis. This person did it to him or herself, okay? Stuck a bead in his ear. A plastic bead was found in this kid's ear. A general anesthetic was required for removal due to the lack of patient cooperation. Yikes! This is rarely, if ever, required for foreign bodies in adults. Syringing is often useful for foreign body removal. Well, here's a type of stenosis. This one's especially for people living down in southern Texas. Here you go. Have a look at this puppy. There's a bit of stenosis for you. You have a bug in the ear. So, excuse me. Bugs like ears, but bugs don't like earwax. Bugs like the temperature in an ear canal is blood temperature, so it's nice and warm. But one of the reasons you have earwax is because bugs really don't like the taste of earwax. This bug somehow got over that and found its way into the ear. And I imagine this person was hearing very loud scratching and whatever, but I know, underlying, oh boy, foreign body. Here's abrasion of an ear canal. Now that's funny that the text under here doesn't really describe the bug so much. Kind of strange. I find that must be a typo in the picture. But here's abrasion of an ear canal. Look at this. Here's a disorder. You're looking at someone who is using Q-tips or bobby pins or matches, and the person was rubbing his ear canal. Now, ear canals are very tender. It doesn't take much to piss one off. I mean, they really react. Look at the blood blisters. Quite painful, and you might even do this with an otoscope. Be careful when looking in an ear canal, because you might just push the speculum against the person's skin. That's why it's always very, very important to brace when looking with an otoscope. I always use my pinky when I'm looking in, and I'll have the otoscope aimed upward, but I'm looking in, and I always brace. And when you're taking any IHS practical exam, a good way to fail that exam is when you're doing otoscopy and you're not bracing. People who hold the otoscope so it's sticking out like this and they're looking in an ear, instant fail. Just remember that. As OTC grads, always brace when holding an otoscope. And you can go on the internet and you can find otoscope bracing techniques, and you'll see them for yourselves. I highly recommend you make it your good business to do so. It's one of them things. All right, we'll take a look at this guy here. Yikes, there's a hematoma, a blood blister. With really aggressive use of cotton tip applicator, evidence of more severe trauma can be found. This can precipitate an otitis externa, ear inflammation external. Look at the eardrum up top. You can see the eardrum, but the inflammation is in the ear canal. Here's external otitis 1. This is an inflamed ear canal, stenosis. You can see it's narrowed, it's infected, okay? With some long name, Pseudomonas aeruginosa. Who cares? Who knows? But severe otalgia. Look at the word here that I'm circling. Make that word part of your vocabulary. Otalgia means ear pain. Oto, ear, algia, pain. No kidding. I'll bet that does hurt. Here's bony exotoses. And you can see again, lumps formed under the skin, benign tumors, the bone, excessive bony growth as a result of stimulation of the canal periosteum, the skin, by frequent exposure to cold, usually from swimming. See? Bony excitoses. Here's an osteoma. In contrast to excitoses, which are common, osteomas are rare benign tumors of the temporal bone, usually lying in the external ear canal. If they occur, they are more likely to warrant surgical removal, as they more frequently compromise the canal. They can block it off. So know the difference between excitoses and osteoma. Here is a perforated eardrum. Okay, given enough time, most cases will heal by themselves. In persistent cases and those with hearing loss, surgical treatment will be required. All right, so they're going to insert a ventilation tube, but they're going to cut open the eardrum in order to get rid of the mucoid otitis media. Mucus, mucoid, otitis, ear infection or ear inflammation, media, middle ear infection. They did a myringotomy, punctured the eardrum to stick something in to suction out the infected fluid. Okay, so here's a picture showing you a myringotomy. Here's a traumatic perforation of an eardrum. Can be done by sudden changes in pressure or direct trauma to the eardrum from an inserted implement, such as a Q-tip too far. In this case, it was a result from a blow on the side of the head. So this requires medical attention, and the doctor may have to do a tympanoplasty to fix this. Here's acute otitis media. Now look at this picture carefully. The eardrum is bulged. Now we're going to look at otitis media next. And we won't finish it all today, but you're going to see this is looking in, the eardrum is bulged. Now in otitis media, it has stages. First of all, the eardrum is retracted. First of all, you've got a negative air pressure behind the eardrum. You know why? I'll tell you the stages of otitis media. It's got chapters to it. Kid gets a throat. We're moving into middle ear now. Okay? Kid gets a sore throat. Tonsils are swollen. What connects the throat to the middle ear? Eustachian tubes. If your tonsils are swollen, when you swallow, no new air gets up into your middle ears. The reason why you swallow is to get that food go down, obviously, but as you know, when you blow real hard, you can force air up into your ears. When you swallow, your eustachian tubes, the end of them, opens up for a split second, allowing new air to get into your middle ear space. Because it's imperative that the air behind your eardrum, how big is that space? About like a sugar cube, okay? That houses the three bones. So that little air space has to have the same air pressure as the air outside. As long as the air pressure on both sides of your eardrum is even Steven, then God's in his heaven and all's well with the world. But if you're getting stage 1 otitis media, sore throat, swollen tonsils, when the kid swallows, no new air gets up there. So now the lining of the middle ear space is constantly absorbing oxygen. And the kid swallows, no new air gets up in there. So now the kid gets a vacuum in the little sugar cube middle ear space. So now the eardrums are like, they're sucked in. After a while, the middle ear rebels against this situation, and it produces fluid. And the fluid is like clear, like under a blister. And that fluid is called serous fluid, S-E-R-O-U-S, serous. It's non-infectious. And now the eardrums begin to bulge. And when that serous fluid becomes infected, which it will, it's going to turn white. It'll no longer be clear. And now it's called suppurative. Let's have supper, okay? But it's S-U-P-P-U-R, not S-U-P-P-E-R. Suppurative otitis media. Some doctors call it purulent, P-U-R-U-L-E-N-T, purulent or suppurative. And that's the picture that I'm showing you here. A bulged eardrum. You can see it's totally bulged. Hurts. The first changes are usually redness of the drum and slight swelling, particularly on the upper half, the pars flaccida. Look at this. Okay. Acute otitis media number 2. As the condition progresses, the middle ear fills with mucopurulent exudate. Look at what it says there. Purulent. Okay? Infected, causing the drum to bulge laterally. Here's mucoid otitis media, glue ear, a chronic infection. Circle the word chronic or write it down. It's different from acute. Acute means sudden and really bad. Chronic means dull and long going. Okay, acute, sudden, and bad. Chronic, moderate, but long enduring. Here, look at this, mucoid otitis media, glue ear. This is someone who's had otitis media for a long time, repeated bouts of otitis media. Prolonged eustachian tube dysfunction, leading to a mucoid effusion in the middle ear. It's the most common cause of mild to moderate hearing impairment in children. This slide shows the classical appearance with a dull appearance to the eardrum and the loss of the light reflex. You're losing some of the cone of light here, indicating fluid in the middle ear and foreshortening of the malleus handle, indicating some retraction. So look at this manubrium handle here where I'm pointing. It stands out even more. It means this eardrum sucked back a little bit. Okay, there's also fluid, some fluid behind the ear. So he's got retraction, but as well as some fluid. Very different from this situation here, where you've got really, it's just acute bulging otitis media due to fluid. This is chronic. Acute, chronic. All right. So now you're looking at mucoid otitis media. The mucoid fluid aspirated or sucked out from the middle ear. Look at how thick it is, a thick fluid rich in aminoglycans and the inflammatory proteins which give it its glue-like consistency. Yikes, isn't this special? So here, look at this fluid here, how yellow it is. That would be associated with this here, okay? But when you're looking here at the clear fluid, that's serous otitis media. And let's see if I can't show you a picture of that. Serous otitis media. There you go. That's the picture looking. There you go. Serous. Okay? It's not white. The fluid is clear. Okay? It's not infected yet. So the stages of otitis media. Look in your notes with me and you'll see them here as we do it. Okay, share screen, get rid of this guy here, pull up the notes and you're going to see right here, otitis media. As we launch into next week's material, look with me at the bottom part of your page 1. Okay, otitis media seen in 70% of Americans before age 2. Put a star by that. Half of these kids experience it again and again. More common in males than females. First Nations, Aboriginal people, people we white people like to call Indians, okay? First Nations people, they are very prone to otitis media. And now look at the stages. Star by each one of these. Begins with a sore throat, upper respiratory infection. Eustachian tube no longer opens when swallowing. Tissues lining the middle ear space absorb air. Now you've got, and I put in italics here, negative middle ear pressure develops. Eardrum retracts, leading to a type C tympanogram. A tympanogram with a bump over negative air pressure. Wonder if I have a picture of it. Not sure if I do, but even here it is. Here's a tympanogram. A type A tympanogram, the peak is over normal air pressure. Whoa, that box here. The peak is over 0. That's a type A, normal tympanogram. Look at type C. The peak is over negative. What does this mean? The eardrum is most compliant. Look at this. Compliance, high compliance, least stiff, when negative air pressure is used outside of the ear. So in other words, I had to use negative air pressure in my ear canal to counteract the negative air pressure behind my eardrum. Negative equals negative. Okay? When the air pressure is even Steven on both sides of the drum, your eardrum is most compliant, least stiff, most efficient. If you have normal air pressure behind your eardrum, your peak of a tympanogram is going to be over normal air pressure in your ear canal, because normal equals normal. If the air pressure behind your eardrum is, I'm going to have to use air pressure outside the drum to make the air pressures even Steven. So the peak of my tympanogram will be over negative. Okay, so make that your business to internalize how tympanometry works, as you've learned in audiometry, okay? So this kid has got early otitis media because the peak of his tympanogram is over negative air pressure. When you get to advanced otitis media, where your eardrum is bulging with serous fluid, or if it's suppurative or purulent or what have you, okay, now you've got a type C turning into a type B. And a type B means a flat tympanogram, because no matter how you changed the air pressure, you made the air pressure positive, you made it neutral, you made it negative, and it doesn't care. There's never going to be a peak, because air pressures can't compete with pus. Okay? Air pressure can't compete with fluid. So tympanometry is really useful in showing the stages of otitis media. Type A, normal. Type C, over negative air pressure. Type B, advanced otitis media. So type C, early otitis media associated with negative middle ear pressure. Type B, advanced otitis media associated with a bulged eardrum. Whether it's serous fluid or purulent suppurative, doesn't matter. So all of these things hinge together. Good. All right. Okay, we were looking at all kinds of stuff here, but again, notice the stages here. Retracted eardrum, early otitis media. Eustachian tubes are swollen shut. No new air can come up into that kid's canals. Why do children get this? Look at this kid. He's got look at how small his face is. Look at how horizontal his eustachian tubes are. The adult eustachian tube is more vertical, so we have gravity working in our favor. When we hit puberty, our skulls change. Here's a baby's skull. Here's an adult skull. Notice how the face got longer. That means that the eustachian tubes became more vertical. And when eustachian tubes are more vertical, you don't get earaches as much. When they're horizontal, you get a lot more earaches. That's why children get otitis media more than adults do. So looking at the stages of otitis media, normal right eardrum, retracted eardrum, early otitis media. Look at how the eardrum is laying on top of the long process of the incus. Here's the neck of the stapes. Look at how the eardrum's laying right on top of the promontory between the oval window and the round windows. It's sucked back. Now you're getting serous otitis media, fluid behind the ear, non-infectious. Now it's turned infectious. So now it's suppurative or purulent. Suppurative otitis media. Advanced suppurative otitis media. They often do pressure equalizing tubes for children who are always getting otitis media. They'll put a tube in the ear to help allow the air pressure to be the same. So tubes in the ear are a non-medicinal treatment. Okay, the doctor does a myringotomy, pokes a hole in the eardrum, and takes a thin tube, okay, and sticks it on top into the eardrum, and this forces the eardrum to stay open, so it's got a little hole in it, and it'll grow out after a few months. The skin, remember, migrates in an eardrum from the center outward, outward, outward. And remember, we even showed you the skin wrinkling in the ear canal as the skin migrates out. So this tube will eventually fall out. But the tube is put in there mainly to keep the air pressure even Steven on both sides of the drum. If it doesn't remain even, if you've got a retraction, your body's going to rebel and it's going to produce fluid, and now you've got a bulged eardrum. Either way, you've screwed things up. It's all about maintaining equal air pressures on both sides of the drum. Otherwise, you'll get otitis media. And that's the first and the main thing we cover in our notes regarding otitis media. That's the biggest middle ear problem in the world. We'll cover other ones, otosclerosis next week and things like that, but the purpose today was to bring you through these stages. Now we get to the top of page 2, and we'll just about wrap up this session here. Mucosotitis media, often called glue ear. Chronic, there's that word, long-standing, difficult to get rid of. Tympanosclerosis, adhesions and calcium deposits left on the inner part of the eardrum even after treatment. Renee's rubbing his face, he can't stand it. And then you've got, in number 4, in untreated cases, mastoiditis. Now that's a bad one. Mastoiditis means, remember what you learned in anatomy? The roof of your middle ear space? How far is that from the brain? 1/8 of an inch. Okay, so if you put your hand on a finger on the bone behind your ear, the mastoid bone is very porous. It's got all full of air pockets. Unlike the petrous portion, which houses the cochlea, Peter, the rock, the hardest bone, the mastoid part, very soft. Porous. They call it pneumatic. It's filled with air holes. Well, infection from the middle ear can crawl up into those holes. And now you are screwed because antibiotics will not help. You will die if this is left alone. It'll turn into meningitis, which is an infection of the fluid lining the brain. Then you're dead. Okay, so mastoiditis was treated by a Black & Decker drill. They'll put you out and they drill away the mastoid bone and they take out the middle ear ossicles, and you are left with a permanent conductive hearing loss because you've had a mastoidectomy. Ectomy means out. Okay, so if you've had a mastoidectomy, you'll notice this on elderly people. Behind the ear, you'll see a deep crack. And you're looking in the ear canal, and it looks really bizarre. Well, they did a mastoidectomy. Today, we don't rely on that as much. Today, you don't see mastoidectomies very much anymore because we treat it with antibiotics, and we treat it with tubes before it ever gets to that stage. Okay? But remember the stages of otitis media. The most common middle ear disorder. So today we've covered outer ear disorders and we've covered otitis media in middle ear disorders. Please review for yourselves and make sure you ingest this knowledge very carefully regarding audiometry and otitis media. Very important. Here's the treatment for otitis media. Antibiotics, put a star by it. Tubes, myringotomy. They'll suction out the treatment. Sometimes they'll put pressure equalizing tubes in the holes where they suctioned out the fluid. Mastoidectomy, not done very often today, but you should read about that. Any tympanoplasty is surgical repair of any middle ear structure. But the treatments should basically, write these down in your margins. The treatments are basically 3 for otitis media. Number 1, the treatment is antibiotics. But people are becoming immune to antibiotics. Number 2, pressure equalizing tubes. Tubes in kids' ears, quite common. Number 3, tonsillectomy. Remove the tonsils. See, I'm of the baby boomer generation. You're not. Any people born between 1946 and 1964 are baby boomers. Okay? We all had tonsils removed. It was de rigueur. It was almost like a natural rite of passage. Oh, you turned 7? Oh, we're going to get your tonsils taken out. People just did it then. Then came the 70s. Hey, man, don't take out the tonsils. They're supposed to be there, man. It's natural. So everybody did tubes. They put tubes in the kids' ears. And they did antibiotics, man. Well, people have become immune to antibiotics. So guess what? The pendulum has swung back to tonsillectomy again. They're starting to do tonsillectomies more often again because people are taking antibiotics and not finishing them. When you take antibiotics and you don't finish the medication, the disease is going to come raging back, and now you've just pissed it off. Okay? Whenever a doctor gives you antibiotics, take them all the way to the end, because otherwise you become your body will become immune to those. Anyway, people have become immune to antibiotics. I've talked quite enough. Make sure you look at your audiometry for otitis media right here. Look at that carefully. Have a good read of that, because next week when we start our Zoom session, that's where I'm going to begin. Okay? So we've covered outer ear pathology and otitis media, the stages. You've seen lots of eardrum picatures and stuff like that. We've covered a little bit about what happens to the tympanogram, but make sure you look at this section of the page and jot down any questions you may have for me next week. But we will see you again next week. 11:30, let's try it again. This is the end now then of good old Zoom session number 1 for Hearing Disorders 125. All right, I'm going to grab me a coffee, and then I got to get on what they call the Sky Train here in Vancouver, and I got to go visit a clinical placement site. Yeah, I'm teaching also at a college up here in Canada, an HIS program, brand new one, 2-year program in Vancouver. It's partly online, partly face-to-face. Those students are doing their clinical practicums, and I got to do a clinic visit site. So that's just me. It's good to see you now, 3 of you here. It's always good not to be talking into a blank and empty screen. So thanks for showing up. And I will stop recording right now, and we'll see you later. We'll see you when we look at you.
I've got to point something out to you. Hold on. Oh. Okay, the link you sent on the email,
yep,
you sent for your hosting portal, not for the student.
Oh, okay.
It didn't work. We had to type in our own code that was in part of the link. We had to type in the 9-digit or 11-digit code.
Okay, how did you get to that? Tell me. That's good. I'm glad you brought that up.
All I had to do was the word meeting in the link that you sent, erase it and put the letter J, and I got in.
Okay. That's why I'm leaving this recorded, because now anybody, excuse me, can have a listen to this. But yeah, that's okay. That's my bad. I just copied the link. I just entered the meeting, saw the link, copied it, pasted it in. So basically, in a nutshell, then what did you do? You took out the
word meeting and entered the letter J, just lowercase J.
And it worked.
Yeah.
Cool. All right. Duly noted. Thanks for pointing that out. All righty. Adios.